Good morning and hi everyone. I've got this blood transfusion in obstetrics guideline summarized for you. This is another of the Greentop guidelines, and again, this is for the MRCOG exams. So I hope you'll find this useful, and if you do, then please do give it a thumbs up and subscribe to my channel if you haven't already, and leave a comment if there's any more guidelines that you'd like to see summarized. So, obstetric hemorrhage is the major cause of maternal mortality in the UK and is now the third leading cause of direct maternal deaths, accounting for approximately 10% of direct deaths. Anemia in pregnancy, so very, very important. The first three lines of the slide are extremely important. So anemia in pregnancy in first trimester is defined as hemoglobin less than 110. Second and third trimester is hemoglobin less than 105. Postpartum is hemoglobin less than 100. So it's 110, 105, and 100. Very, very important SBA question there. So if there is normocytic or microcytic anemia, then a trial of oral iron is something that should be given first, and HB levels should be repeated at 2 weeks. You can offer screening for anemia, including doing a blood group save, including checking the antibody screening status at booking and at 28 weeks. In a multiple pregnancy, you want to do an additional full blood count at 20 to 24 weeks as well. Now, after offering oral iron, and if for whatever reason that doesn't work, you can offer patients parenteral iron. So that's iron in given intravenously. So either there is problem with tolerating oral iron, or it's not being absorbed, or there is problems with patient compliance, or the woman is approaching term and there isn't enough time to give oral iron and wait for its effects. In that case, you can give parenteral iron. Patients should also be informed about rich sources of iron in diet, so like things like red meat, fish, and poultry. These sources provide heme iron, which is quite quickly absorbed. Vitamin C enhances absorption of non-heme iron. Tea and coffee inhibits iron absorption from food. Active management of third stage of labor should be advised for patients with anemia. If there's a patient who has high risk of hemorrhage, they should be advised to deliver in the hospital setting only. So consent for blood transfusion should be taken. So it should be valid consent. It should be documented in the notes clearly. In an emergency situation where blood needs to be given and there's no time for consent, then this information should be provided retrospectively. So information provided should obviously contain things like benefits and risks of a blood transfusion. The reason for transfusion and the consent, as said, should be documented. If somebody has a hemoglobin of less than 70 in labor or in immediate postpartum period, then after reviewing their history and their clinical signs and symptoms, a decision should be made for blood transfusion, and there should be quite clear guidelines in your trust as to when this should be administered. So any group in screen samples taken in pregnancy hopefully should not be less than 3 days old. In high risk of emergency transfusion, things like placenta previa, then and there's no clinically significant antibodies, then group and screen samples should be sent once a week at least. So there is an up-to-date sample in the lab just in case blood transfusion needs to be administered to this patient. So blood product specifications. So obviously the blood group should be matched for ABO blood, blood group, rhesus status, and K compatibility. If red cell antibodies are present, and then blood is negative for relevant antigen, should be cross-matched before transfusion. So for that particular antibody, you should make sure that the blood group you give so blood transfusion that you're giving hasn't got that particular antigen within it, and this specific blood cross-match should take place before transfusion. CMV negative red cells and platelet components should be used for transfusion. For cell salvage, again, consent should be taken, and it should be used if there's anticipated blood loss is going to induce anemia or is going to exceed 20% of estimated blood volume. Cesarean section in rhesus negative women, and where they have received cell salvage bloods and the cord blood has confirmed rhesus status as positive or unknown, minimum dose of 1500 international units of anti-D immunoglobulins should be administered. Then a blood test should be taken 30 to 40 minutes after the cell salvage products are given, and also the 1500 units is given to check whether for fetal maternal hemorrhage, and also whether there is any further dose of anti-D that is required. In extreme situations, if blood group is unknown, group O, rhesus D negative red cells should be used. FFP dose of 12 to 15 mL per kilo for every 6 units of RBC should be used in a major obstetric hemorrhage. Aim for PT, which is prothrombin time, and activated partial thromboplastin times, that's APTT, ratios of less than 1.5 times the normal. Regular FBC and coagulation screening should be done during the bleeding. Cryoprecipitate should be used, and the standard dose is 2 5-unit pools, and subsequent doses should be given based on the fibrinogen levels and AIM levels of more than 1.5 grams per liter. FFP and cryoprecipitate should ideally be the same group as the recipient. If for whatever reason it's unavailable, FFP of a different ABO group is acceptable, providing that it does not have a high titer of anti-A or anti-B activity. No anti-D prophylaxis if rhesus negative women receives rhesus positive FFP or cryoprecipitate. If platelets, so aim for platelet counts of above 50 multiplied by 10 to the times to the power of 9 if there is an acute bleeding. So trigger for platelet transfusion should be platelet count of 75 times 10 to the power of 9 per liter is recommended, and aiming for counts above 50 all the time. Platelets should be group compatible and rhesus negative. If a woman is declining blood products, and how should this be managed? So HB should be optimized prior to delivery, so to reduce risk of anemia during delivery and during the postpartum period. Consent and refusal should be documented very clearly, because even though patients might refuse blood products, there's so many different types of blood products, so your platelets, your red cells, your all the different types of FFP and the coagulation stuff that you can give. So it's very important to document exactly what the patient is refusing and ready to accept. So in an emergency, things can just be acted on. So all these discussions should be clearly happening in the antenatal period. Pharmacological, mechanical, and surgical procedures should be used early to avoid major hemorrhage for patients with declining blood transfusion. Again, cell salvage is one of those things that, again, some patients will be happy with and others will not. So a discussion needs to happen whether the patient will accept it or not, so that this is also documented very clearly in the notes. And if needed, then cell salvage can also be administered, whereas some patients would decline it. So this can obviously be withheld if they decline. Well, that's it. That's your blood transfusion guideline summarized for you quite quickly and quite briefly with all the important salient points. I hope you found this useful. Please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. Also share this with your friends and colleagues who might benefit from this important guideline summary. And good luck with your revision. If there's anything I can help you with in terms of any specific guideline summary or talk summaries that you'd like to watch, then please do write in the comments down below, and I will make sure that I get those summarized for you. Thanks for watching.